Welcome to the Caregivers Compass, where we guide you through the journey of aging, caregiving, and life's most important transitions. I am BreJeanna Webb, a senior care and transition strategist, licensed realtor, and the founder of Compass Senior Living Advisors.
And I'm Crystal Godette, Director of Clinical Quality and Program Development, here to help you understand the care side so you can make confident, informed decisions. Together, we help families navigate senior care, housing options, and emotional decisions that come with it so you don't have to do it alone. Let's get into today's topic.
When families hear the word hospice, fear immediately sets in.
So, with that being said, let's just go ahead and understand what that looks like. We'll break fear, stigma around hospice, educate families on what hospice really is, and position hospice as more so support, dignity, and quality of life, not just giving up.
Hmm. Today, we're having an honest conversation about hospice, what it is, what it isn't, and why many people are afraid of it.
So, with that being said, we are here with our special guest, Ms. Shawn Jenkins. We're joined by Shawn, who is a hospice professional who's giving us just helping us break down the answers and questions that families may have or are afraid to ask. Shawn is a hospice liaison with a company called Bristol Hospice. Her passion for hospice actually comes from personal experience with her great grandmother, where she saw firsthand how much earlier support could have helped her and her family. Now she's on a mission to help people understand that hospice is not a death sentence, but compassionate, supportive care that's focused on comfort, dignity, and quality of life when it matters most. Let's get into it. Hey, Shawn.
Hi, everyone. Thank you for
Hello.
Hello.
having
Tell us
me.
about yourself.
Well, you did great. I I'm Shawn. I'm with Bristol Hospice. I'm a liaison. So my main job is to go around and educate about hospice and bus myths and just let people know, like you said, what it is and what it isn't. And I enjoy doing so every day.
How long have you been working in the hospice realm?
Honestly, I've only been working in hospice for 2 years now. I started off with Bristol as their volunteer coordinator. And
Oh,
so I would rally up volunteers and get them to go and sit with the patients and give compassion and just do little light things for them. And in that role, I got to see more so how much education is needed in the field. Um, I saw patients in the hospital who was on their dying bed, and didn't take advantage of the benefit of hospice. Like they got
mm,
it at the very last hours. Um, and I wanted to make it my mission to teach people that they can take advantage of the benefit way sooner and get comfort way sooner. So that's what made me transition into this role. And I've been in this role itself for 1 year, a little over 1 year.
Okay. Now, you mentioned bus myths. So
mhm.
we're going to start with 5 myths and have you to respond. So the
Okay.
first myth is a hospice means death is happening immediately.
Mid bust. So definitely not. We have patients. It's basically that just an extra layer of care. Like if a patient has a terminal illness or a terminal diagnosis, and it could be something as much as dementia. That's a terminal diagnosis. Now, the trajectory for that disease is different for everyone. So that's how we end up with patients on services for months or even years. Now, Medicare guidelines, they do require you to have a diagnosis like with a prognosis of estimated 6 months left to live. But who knows, you know? And so if you have you're experiencing declines and things like that, you can have hospice support, you know? And so you don't have to be, 1 foot in and 1 foot out. You can take advantage much sooner than that.
Okay. So you spoke earlier about just people getting that care at the very last second. So That takes us to myth number 2. So myth number 2 is hospice is only for the last few days of life.
Yeah, again, it is not. But I mean, I understand, right? That's what we were taught back in the day. That's how it was. Oh, grandma is about to die, so let's call hospice. Within a week, she's gone. But no, it's not that way anymore. As soon as you start experiencing those declines, people don't realize frequent emergency room visits, losing weight, losing the ability to take care of yourself, your ADLs, maybe not completely. You may can, 3 out of 6 of them, toileting or, incontinence, things like that. So no, it's not for the very last days of life. It's to basically give you a quality of life for the remainder of life that you have.
Mm-hmm.
And we're hoping that it's, you call us way before a few days.
Right.
Now, I heard a couple of key words from you. You use the word take advantage, the words
Mhm.
take advantage, and then the word benefit. Myth number 3 is they stop feeding you and they stop the care for your loved one.
Yeah, that is horrible. Definitely myth bust. We continue to feed you. We won't force you to eat. So some families, like depending on when they call, so some families may see that their loved ones started to not want to eat as much. We won't force you to eat, but we continue to attempt to feed you and to attempt to give you the nutrients that you can handle safely. um, as the dying process, you know comes near, that's one of the things that your body starts to not need as much food or want as much food, and it's okay. Some people don't want to, you know, come to grips with that. But say you're 6 months or 8 months or you have a while, we're not gonna we never stop feeding you. We continue to try to give you everything that you need, food, drink, everything that you need to keep you thriving. We don't hasten death at all. That's a big one. We don't hasten death. We try to keep you comfortable. We try to give you that quality of life, dignity, continue to feed you, continue to nourish you as much as your body can accept, allow.
Absolutely.
Yeah.
And other myth. So once you're in hospice, you're locked into it. You cannot, change your mind once you start. How do we feel about that?
Myth bust. And so that's one of the beauties of hospice, and I do consider it a benefit. Um, you can try it out. It's a scary word, right? Because it has a little stigma to it because of what we thought from back in the day. So it's a scary word, and you can try it out and say, "Oh, you know, I don't think this is for me. I don't want to, I don't want to. I think I do want to seek aggressive treatment, right? I think I do want to keep trying. You can revoke it and try your aggressive treatment. Try different paths. Do different things that you feel like you need to do that you can't do on hospice, which is the main thing that you can't do is seek aggressive treatment because hospice is shifting from curative care to comfort care.
Mhm.
And so say you did get off and you're like, you know what, this is too much for me. I was enjoying the aid coming. I was benefiting more from, you know, the nurse coming to me instead of me running around to doctor's appointments. I want hospice back. You can requalify for it. So you can get off, get on, get off. They don't like us saying that too much because we don't want you yo-yoing back. But it is an option. You're not stuck at all.
Right.
So
Yeah. And
yeah.
I can say, like, BreJeanna and I have both, as therapists, seen people, quote unquote, phase out of hospice.
Yes.
Yeah.
Yeah. I've seen it. We've had patients who, and I'm not on the clinical side, and so I see a patient come in and I meet them for the first time, and I'm like, oh, look like they're not going to be with us long. And then I see them again in 2 weeks, and they're talking and saying, "You got any candy in your purse?" And and next thing you know, they're phasing out, and
Yeah.
that's a beautiful thing. Um, it doesn't happen to everyone. So we never want to give a hope either way,
Right.
but it does happen. It does happen a lot.
Yeah,
Because sometimes,
definitely anomalies.
yeah, sometimes people get actually better on hospice or do better on hospice than them trying to manage the disease or the symptoms on their own, because your body is stressed when you have all this pain and you're tensed up, and so when we come in, we give that comfort and care and kind of even you out, then you can thrive a little bit better.
Okay, so our fifth and final myth is hospice is only for cancer patients.
Myth bust. And I'm trying to think of the exact year, but it was only a few years ago where cancer was the number one diagnosis. But now, 2026, and up from 2024 to 2026 at least, um, Alzheimer and dementia has been the number one hospice diagnosis. And so we see patients from COPD, CHF, of course, cancer, Alzheimer's, dementia, um, end-stage renal disease. The list goes on. And I believe most hospices, but Bristol for sure, we focus mostly on prognosis versus diagnosis. You know, how's that person doing? Yeah, they have this disease, but this disease may make someone go completely down and the other person may be thriving, with the disease at the same stage. So we focus more on that person, individual being, and how their body is handling things versus what their actual diagnosis is.
Absolutely.
Okay.
So we'll get into some foundational questions for the people. First question being, what is hospice and how exactly would you explain it to someone that's hearing about it for the first time?
I would explain it as hospice is comfort care. And what that means is you're not seeking aggressive treatments, you're not seeking a cure. Say that, like, I met someone, I won't say any names, I met someone who have a cancer and they just don't want to go through it. They feel like they're old enough, they've lived life, and they just don't want to go through it, through the process. So switching from curative care to comfort care, you don't want to go through the aggressive treatment. So it's basically extra support when you need it the most. We come in, we have a nurse that comes to you, we bring your whole care like a SWAT team to you. So we bring your nurses to you, we bring your home health aide to you, um, what's it, social worker support. And social workers are good because a lot of families don't know, like, this is the first time they're in this position, and so they don't know the extra resources that they may can pull on, or some type of estate planning or different things like that can a social worker can help with, chaplain support. So it's basically you get a team of individuals that come together for your care, and we bring it to wherever you call home, whether it's a nursing facility, your personal home, homeless shelter. We come wherever the person calls home and support them. And it's not just for the individual. Hospice is for the family. And so we help the caregivers. We support them during the time because it's a lot for them. We give extra bereavement support even once the patient passed, for 13 months past the person passing. We give extra bereavement support. Respite care is a big one I really like to push, because caregiver burnout is real. And so you're caring for your loved one. You love them, yes, but you need a break. You want to go somewhere, you want to do something. So respite support is big with hospice because it allows you to go and take your break 5 days every month, once a month, if you choose 5 days, and we'll take your loved one and put them in one of a facility that we're contracted with. So a nursing facility, and we pay for it. Hospice pays for it 100%. Take care of them so you can go on your trip or whatever for 5 days and not worry about it. So that's what I mean when I say it's for the family. It's not just, for the individual. So it's a holistic approach.
So I have a quick question.
Yes.
that respite support service, is that for hospice in general or for the company that you represent?
Hospice in general, office respite. Now, each hospice, um, it depends on who they're contracted with. So we are actively seeking contracts with uh, reliable sources as far as, different nursing homes and things like that. So respite is great, but some hospices may be small and don't have contracts for certain places.
Mhm.
And so each hospice has respite support, but
Mhm.
who they're contracted with to care for your loved one may be different.
Okay. But
Mhm.
hospice pays for
Hospice pays
it.
for it.
5 days a month.
Right, 5 days a week, 5 days a month. Yeah. And Medicare is hospice is a benefit of Medicare. 100%. Now we do take private insurance as well, but Medicare 100% pays for your hospice. So that's where the respite and some of the other benefits come from as well.
Mhm. And I want to have a commercial break really quickly. If you are finding any of this information valuable, I ask you that you like, you share, you subscribe to our YouTube channel. You never know who's looking for answers to questions and they can't really find the answers. Send them our YouTube channel. We are dedicated to be a solution to all of our caregivers and the clients in their time of need and transition. So thank you for that moment commercial break. And we'll get back to our next question. And you've answered a lot of questions, even in
Yeah.
your one statement. Um, I want to ask you who qualifies for hospice?
And so, who qualify for hospice? Going back to some of those diagnoses that we see or the prognosis. So, we do a hospice evaluation. So, if it's a family member or say a social worker at a facility sees a patient and they've been having dementia or whatever for a while, but they were doing pretty good. But now you see they're getting more confused, or they're having an unsteady gait. You're seeing frequent falls, or they seem to have lost a lot of weight within a short period of time. Those people warrant a hospice conversation. And so,
Mhm.
as far as qualifies, it's a very individualized approach. And so, if they have any of those terminal illnesses, that'll be um, a starter. So, any terminal illness, comorbidities as well, like multiple comorbidities, like diabetes, on top of having a COPD or
Mhm.
CHF, things like that. But prognosis, like how are they doing overall? And so, a lot of people are scared to even mention hospice, but it's just a conversation. It's just an evaluation to say, let's see if we can give you extra support. Um, so
Mhm.
I don't like to say this person qualifies or that person doesn't. It's a very individual approach. So if you even think that, I like to say this, I said this recently. So if the idea comes to your mind, I wonder, it warrants a conversation. So
Yeah.
I wonder if they could benefit. Let's see. Let's talk about it. And a talk doesn't mean we're going to pressure you or anything. It's just giving you the facts, seeing how you are, seeing what you could benefit from, and going from there.
Mhm. Okay. Well, earlier we spoke about, right time to start, it's just depending, but you don't want to wait too long. But what happens if a family waits too long? Like what would you say that looks like on the family, on the patient, just on the individual? What would that look like if you're like, you know what? This seems like you guys waited just a little too long to start this conversation.
Yeah. I mean, I would say too long. It's best to try to have the conversation early. Um, it's never too late,
Hmm.
but when it's urgent, it's a bad experience for everyone. It's a bad experience for everyone. And when I say that, the hospital. So if you're already in a hospital and you have no other choice. Everyone has to make the decisions for you. It it puts the family at a bad disposition. I'm trying to put it because I can see the whole walkthrough. So what happens in a hospital setting, the patient comes in a dire way. The hospital calls us and say, hey, this patient needs hospice. They need it immediately. We're like, okay, we're coming, because in a hospital setting, they have to give medications at a certain interval. Hospice can give it more frequently to calm those symptoms and pain. And so if you have to be called for hospice in the hospital setting, it's dire. And we like to try to have that conversation before it gets that far. To me, I would, if I had to say when it's too late or it's too far, that would be it. But because at that point you haven't really taken advantage of all the benefits you could have. And now you're taking advantage of it at that moment, because we're going to come and calm the pain and do everything we can to get you peaceful and comfortable. But your family has to make a decision right then and there. This is an emotional state. I'm dealing with my loved one. You want me to sign papers? You want to know what their insurance is? You want to know this? You want to know that? I don't have time for that right now. That's a bad time for anyone to handle business. And so that's why I like the conversation to happen early. Put it in place. Grandmother, mom, uncle has this or that going on. Put it in place early, because when it gets urgent, it is not pretty. And that's why people get this negative thought about hospice, because when my grandmother was in hospice, I had a friend told me this, and I talked to her and she felt better afterwards. But when my grandmother was in hospice, they came and they rushed in and hospice took over, and then she died. And hospital called us because they saw that coming. It wasn't anything that was done, but it gives you feel like you're being rushed around and you got to make decisions and things like that. But once it's in that hospital setting, it's urgent, and you're not going to have a good experience. It's going to feel terrible. It's going to feel terrible.
So we have so many questions that I think we're going to go ahead and wrap this episode up, because it's so many questions to have. And I want to go ahead and wrap this episode up. We're clearly going to have a part 2, maybe even a 3 at this point. We're going to wrap this episode up and have you back as a guest for at least part 2. So Crystal.
So we are giving a call to action right now. So if this video helped you understand hospice differently, then share it with someone or anyone who you think may need it, or everyone that you think may need it. And also comment in our comment section. Just comment the word hospice if you'd like a caregiver guide to comfort care support. And of course, remember to subscribe for more conversations that help you navigate caregiving with confidence. And of course, in part 2, we will have Shawn back, because we have so many more questions for her. So thank you guys so much for joining us. And BreJeanna, go ahead and let them know what they need to do next.
Yes, and remember, hospice is not about giving up. It's about shifting the goal from curing to comfort. Also, making sure that your loved one is cared for with dignity, peace, and support. And again, if you would subscribe to our YouTube channel and share this with someone that is in need of our solutions. Thank you, and you have a great day.